which you have already taken this lecture. You must know what is antepartum hemorrhage. So what is antepartum hemorrhage? Anybody knows? What is antepartum hemorrhage? Anybody? So it is the bleeding from the genital tract after 24 weeks of pregnancy, during pregnancy. So this is how we define antepartum hemorrhage. So it is bleeding from the genital tract during pregnancy after 24 weeks of gestation. Before 24 weeks is called miscarriage. So antepartum hemorrhage, there are two types of main reasons for antepartum hemorrhage. One is abruptio placenta and the other is placenta previa. And the others include local causes. So today we will discuss abruptio placenta. What is placenta? You already know what is placenta. So, placenta is an organ, intrauterine organ, which supplies nutrients and oxygen and blood to the baby, and it is normally sited in the upper segment of the uterus. When this placenta separates from the uterine wall, this is normally implanted placenta, it separates from the uterine wall after 24 weeks of gestation, it is called abruptio placenta. This is the premature separation of the normally sited placenta after 24 weeks of gestation. So as you can see over here, this is the placenta and it has been separated from the uterine wall. This is the uterine wall, and this is the collection of blood between the uterine wall and the placenta. So this is abruption, and from here this placenta is attached to this cord to the baby. So this is abruptio placenta. Here again, this placenta is lying in the lower uterine segment, it is not normally sited placenta, and it is separated from the uterine wall, and this is completed in the cervix. So there are premature separation of placentas from the uterine wall. This is normal placenta. This is the uterine wall, and this is the normal placenta, which is attached to the uterine wall here. Here you can see this is placenta and this is the uterine wall, and in between there is a gap which is filled with the blood. So this is detached placenta or separated placenta. So when this placenta separates from the uterine wall, what happens? The blood trickles down through the cervix into the vagina. So this is revealed hemorrhage. And if it keeps on collecting behind the placenta and does not come out, that is called concealed hemorrhage. Almost 1/3 of all antepartum bleeding is due to the abruptio placenta, and its incidence ranges from 175 to 125 births. Abruptio placenta recurrence, the recurrence rate is 5 to 17% after one previous episode of abruption, and up to 25% after two previous histories of abruption placenta. So it doubles. What is the causes? What is the cause and what is the etiology? Most of the cases they rupture placenta is uncertain, unidentified cause, and several associated can be identified in other cases, like increase in age, advanced maternal age and parity, preeclampsia, raised blood pressure, and preeclampsia and chronic hypertension. If there is sudden preterm premature rupture of membranes, or there is multiple gestation, or any kind of trauma, suppose a pregnant lady is hit by her baby on the abdomen, or she falls from the motorbike, she has a road traffic accident. All these traumas they can lead to separation of placenta from the uterine wall. Cigarette smoking is another factor which may contribute to abruption placenta, while cocaine abuse, and if she has previous history of abruption placenta. Uterine fibroids. If a placenta is attached to the uterine fibroid, submucous fibroid, it may separate prematurely. And in case of polyhydramnios, when there is sudden rupture of membranes, it will lead to gush of blood and abruption of placenta. A gush of fluid, and there will be sudden decompression of the uterine wall and will lead to abruption of the placenta. So this picture shows high blood pressure. Either this is pregnancy-induced hypertension or chronic hypertension, or she is a chain smoker. She does not quit smoking during pregnancy, or advanced maternal age, and the maternal age is over 40 years, and multiple gestations, multiple pregnancy. There is overdistended uterus and larger placental site, and it may lead to premature separation of placenta. Abruption placenta can be of two types, mainly revealed hemorrhage or concealed hemorrhage. In revealed hemorrhage, there is external bleeding, while in concealed, there is no bleeding, and maternal shock is out of proportion of the bleeding. And it is mixed type in which there is combination of both revealed and concealed. So in concealed, it is about 20%. The hemorrhage is confined with the uterine cavity, dashed placenta may be complete, and the complications are severe. In revealed type, that is in most of the cases, that is 80%, the blood seeps out of the cervix. The placenta detachment is more likely to be incomplete, and the complications are fewer and less severe. As you can see over here in this picture, this is normal placenta. This is abruption placenta. The normal sided placenta is detached from the uterine wall, and there is blood in between the uterine wall and the placenta. Here, placenta previa, the low lying placenta into the lower uterine segment. This is lower uterine segment and this is the upper uterine segment. So if the placenta is situated in the lower uterine segment, then it is called placenta previa, which is another major cause of abruption, antepartum hemorrhage. So again, this picture shows that this is revealed hemorrhage. The blood seeps out of the cervix into the vagina, trickles down, while in concealed variety, this is placenta and this is the uterine wall, and the blood is confined in between the two. It does not trickle down through the cervix. So this is concealed type, which is more dangerous and more severe, and it has high complication rates. Again, the picture shows concealed hemorrhage. This is concealed hemorrhage or internal bleeding, not coming out of the cervix, while this is placenta previa with abruption, and the bleeding is coming out of the cervix. So this is revealed hemorrhage, but the placenta is placenta previa with abruption. Now, these are The degree of abruption. Here, this placenta is partially separated. It is attached over here, separated from here, and again attached over here. So this is partially separated. In this case, there is also partial separation, but there is revealed hemorrhage. Placenta is separated, but it is partially and over here. It is attached over here and it is separated from here, and here the bleeding comes out and trickles down through the cervix. This is complete separation of placenta and concealed hemorrhage. The whole of the placenta is separated from the uterine wall, but it is concealed hemorrhage. The blood is not trickling down through the cervix. What is the pathophysiology? Placental abruption is initiated by hemorrhage into the residua visualis. So whenever there is separation, there will be bleeding in between the placental bed and the uterine wall. This bleeding, it will cause hematoma formation. In concealed type, this blood will keep on accumulating and increase in size of the hematoma. And the blood may seep into the myometrium, into the uterine wall, and it will make it a Couvelaire uterus. The Couvelaire uterus has all ecchymotic patches on the uterine wall. It was first described by Couvelaire in early 1900. There is extravasation of the blood into the uterine vasculature, and it is beneath the uterine serosa. It can be seen only on naked eye. These myometrial hemorrhages interfere with the uterine contraction leading to BPH. So what happens whenever these microclots are formed in between the uterine wall? It interferes with the uterine contractions, and when there will be no uterine contractions, there will be urinate only, and the patient will go into severe BPH. This is a Couvelaire uterus. This is how it appears on naked eye. It is all bruised, small ecchymotic spots. So it is all bruised, and when you open, it is all ecchymotic, all bruised. This is Couvelaire uterus, so it will not contract. So if the blood goes into the myometrium, it will form Couvelaire uterus, and the blood gains access to the amniotic fluid through ruptured membranes. If disrupted placental site is reduced metabolic exchange. So what will happen when the placenta is separated? The oxygen supply to the baby is compromised, and it will lead to fetal hypoxia. And if the process continues with the release of tissue thromboplastin in the maternal circulation, so when this eritoplacental clots use up all the fibrinogen, and thromboplastin is released into the circulation, maternal circulation, and it will lead to DIC, disseminated intravascular coagulation. A patient with abruption, how it will present? It may present with vaginal bleeding in 80% of cases or not. Uterine tenderness, backache, back pain, fetal distress, hypertonic uterus. On palpation, the uterus will be woody hard, and the baby may die in 15% of cases. So fetal demise. The patient will present with acute abdominal pain, painful uterine contractions, and when you check the fetal heart, there will be decreased fetal heart rate or fetal bradycardia. This is how, when you do CTG, there will be fetal bradycardia. This is the baseline, and this is the deceleration. This one deceleration, and again here it is deceleration. Again there is another deceleration. So this is the sign of fetal distress. Repeated decelerations. These are type 2. These are type 1, and these are type 2. And this is variable. can we, how can we diagnose abruption? Abruption is a clinical pure clinical diagnosis on the basis of history and examination. This triad of symptoms, external bleeding, uterine contractions or abdominal pain, and fetal distress. So, whenever this triad of symptoms appear, then you must suspect abruption. Digital examination or vaginal examination should not be done until placenta previa or vasa previa. Ultrasound, it has limited value for the diagnosis because the larger abruptions, they have hypoechoic areas seen in underlying placenta. So sometimes it is difficult to differentiate between abruption and the placental clot in the placenta. This is an ultrasound picture showing abruption placenta. This is fetus head. This is the back body of the baby. This is liger, and this is the amniotic cavity. This is placenta. This is the uterine wall, and placenta is separated from here from the this uterine wall. See, as you can see over here, placenta is separated, and these are the retroplacental clots, as seen in the ultrasound. Again, this is placenta. This is uterine wall, and this is the amniotic cavity. Placenta is separated from the uterine wall in this area, and this is the retroplacental clot. This is the naked eye appearance of the placenta, which is abrupted. This area is the site of abruption, while this is not. So this is the site of abrasion in which you can see the retroplacental clots attached to the site of placenta. So the lab test. So how the main diagnosis is clinical. Whenever patient presents with bleeding, with uterine tenderness, and there is fetal bradycardia or absent fetal heart sounds. On clinical examination, the uterus is, the abdomen is tense and tender, woody hard. Uterus is woody hard, and the uterine contractions, they are not felt separately. The uterus is tonically contracted. Whenever you find a woody hard uterus, tonically contracted with vaginal bleeding, fetal bradycardia, or absent fetal heart sounds, you must be clear that this is abruption placenta. So this is clinical diagnosis, and you can take the help of ultrasonography to rule out placenta previa, and if it is normally sighted placenta, you may or may not see the retroplacental clots. The lab tests which should be done in such cases, it includes critical count, blood grouping, and cross-matching, urine analysis, renal function tests, prothrombin coagulation screen, fibrinogen level, and FTP. So these three tests, these include in respiratory count into coagulation screen. Classification depends on the history and investigations. Grade 0 abruption, when it is asymptomatic and it is incidental finding of retroplacental clot after delivery. Grade 1, vaginal bleeding, but there is no maternal fetal compromise. Uterine tenderness present. This is grade 1. Grade 2, when there is fetal distress, but there is no maternal evidence of fetal shock. Vaginal bleeding may not be present. This is grade 2. In grade 3, maternal shock with fetal demise and marked uterine tetany and tenderness and vaginal bleeding may or may not be present. Again, grade 0, no clinical features, and this is incidental finding on inspection of the placenta after delivery. Grade 1, vaginal bleeding slight, uterus has minimal tenderness, and maternal vital signs, feminine levels, and fetal sounds are all normal. Vaginal bleeding in grade 2 is mild to moderate. Uterine tenderness is present, maternal health, there is tachycardia, and emission levels are decreased, and there is fetal distress or fetal death. So this is grade 2. In grade 3, raised vaginal bleeding severe, and uterus is markedly tender, patient is in shock, fetal death occurs, and it is associated with anuria or coagulation disorder. How you will manage? So up till now we have discussed what is a blood sugar placenta, what are the different types, disconceived, bereaved, or mixed type, then what are the risk factors which may contribute towards a blood sugar placenta, and then what are the different grades of abruption, whether it may be grade 0 or grade 3. Grade 3 is severe abruption with maternal shock, fetal demise, and there is renal failure along with coagulation disorders. So diagnosis is mainly clinical. So what is the diagnosis? So what happens when a patient presents to you in labor? She has severe abdominal pain, there is vaginal bleeding, and when you palpate the uterus, it is very hard in consistency. And when you try to hear the heart sounds, either there is fetal demise or there is severe fetal distress, fetal bradycardia. So when you find these triad of symptoms, that is vaginal bleeding, uterine tenderness, plus fetal distress or fetal demise, then the first diagnosis that comes to your mind is abruption syndrome. Now, such patients, how you will manage? You will send baseline investigations, CBC, along with blood grouping and cross matching. You will group and save, and you will send renal function tests and regulation profile. Regulation profile includes platelet count, APT, APTT, and PT with serum fibrinogen level and FKPs or D timers. So after sending investigations, you will, if the patient is in shock, you will manage the shock. How you manage a shock? You will pass large or IV cannulas. You will give a the patient shock in a hose line or plasma expanders, and if blood is available, you will attach blood. Pass for this catheter to monitor the urinary output, record maternal signs, and also continuous fetal heart rate monitoring with CTG. If the patient is RH negative, administer anti-T injection. Now, the management depends upon the gestational age and the condition of the mother and the condition of the baby. If mother is hemodynamically stable, gestation is down, and baby is okay, there is no fetal distress, then what we can do in mild abruption, then we can do uh, induce the labor, induction of labor, and we can deliver the baby with continuous CTG monitoring. If term gestational mother is hemodynamically unstable, we will rush the fluids, transfuse packed RBCs, fresh fluorescent plasma, or platelets as needed. Maintain the fibrin level more than 150 mg per deciliter, and the hematocrit should be more than 5% if platelet 60. 65. Urgent CS is needed only if there is fetal distress. Otherwise, vaginal delivery should be done. If there is preterm baby and patient is hemodynamically unstable, in the absence of labor and preterm, then the patient should be managed conservatively. So if patient is stable, there is mild bleeding, is settled down, and the baby is preterm, less than 7 weeks, then what we will manage conservatively. We will do serial ultrasound scans to see the fetal growth and also to see the fetal growth and the cyclic absorption. Steroids should be given to promote fetal lung maturity so as to uh, deliver if there is need of delivery, we can deliver the baby. If there is maternal instability during this conservative period, or like patient goes into shock, there's severe bleeding, or the fetal distress occurs, then we will do delivery. Then we will not manage conservatively. We will deliver the baby either through cesarean section or by inducing the labor, depending upon the condition of the mother and the baby. And if there is preterm gestation, less than 7 weeks of gestation, and the mother is hemodynamically unstable, she is in shock, delivery should be performed after appropriate resuscitation. This is a flowchart for the management plan in APH Placental. If the patient is in shock, massive hemorrhage, and patient in early labor or in primary gravida, or the cervix is closed. ठीक है, शॉक में है पेशेंट, मैसिव हेमरेज है, अर्ली लेबर है, प्राइमरी ग्रेविटा है, सर्विस क्लोज है आपने उसकी बेबी की, then we will deliver immediately by emergency cesarean section. ठीक, if emergency cesarean section is not possible, suppose emergency cesarean section नहीं हो सकता, there is some reason, then you will do prompt vaginal delivery. How? You will induce labor by amniotomy. You will start centrosinon to speed up the labor, give analgesics, and in second stage, instrumental delivery. And after that, you will explore the placenta and the uterine cavity and give uterotonics after removal of the placenta. And hemodynamic monitoring is continued even after delivery. So either the patient is not in labor or the patient is in labor. If patient not in labor, then emergency cesarean section. Excuse me. And if emergency cesarean section is not feasible, there are some reasons. Either the anesthetist is not available or there is some problem. Then you will do prompt vaginal delivery. So you will expedite the delivery by ARM, early ARM कर देंगे, साथ सेंट्रोसिनॉन लगा देंगे, साथ ही उसको आप एनाल्जेसिया दे देंगे. जैसे ही वो फुली डायलेट होगी, आप वैक्यूम लगा के उसको कर देंगे. जब प्लेसेंटा रिमूव करेंगे, आपने यूट्राइन कैविटी भी एक्सप्लोर करनी है, प्लेसेंटा को भी आपने इंस्पेक्ट करना है कि पूरा निकल आया है, और अंदर आपने यूट्राइन एक्सप्लोरेशन करनी है कि पूरा इंटर भी पीस में है क्या, और उसके बाद आपने उसको मॉनिटरिंग उसकी कंटिन्यू रखनी है आफ्टर डिलीवरी ऑल्सो. If during emergency section there is uterine atony, bleeding process, then you will manage conservative surgical treatment with venous लगा दें उसको, जब भी आपकी यूट्राइन पैकिंग कर दें. अगर उससे नहीं फायदा हो रहा, it is not effective, then we will do hysterectomy to stop the bleeding. This is the final or radical treatment for the atony uterus. If all the measures fail, कि डिवास्कुलराइजेशन भी आपने कर दी हुई है, यूट्राइन पैकिंग भी कर दी है, ब्लीडिंग स्टिच भी लगा दी है, अगर उन सब से ब्लीडिंग नहीं रुकी, then we will do ultimately hysterectomy. So this is the flow chart which shows how we will follow. पेशेंट शॉक में है, लेबर में नहीं है, हाउस क्लोज्ड है, इमरजेंसी सेक्शन. लेबर में है पेशेंट, या फिर एडवांस डायलिटेशन है और मल्टीपैरा है, उसमें हमने क्या करना है, उसमें फ़ौरन हमने उसका नॉर्मल डिलीवरी की कोशिश करनी है। एम्ब्रियोटमी करें, सेंटर लगाएं, एनेस्थीसिया दें, इसको वैक्यूम से इंस्ट्रूमेंटेड से डिलीवर करें, बाद में एक्सप्लोर करें प्लेसेंटा, यूट्रन कैविटी भी और प्लेसेंटा को भी देखें, और उसके बाद कंटिन्यूस मॉनिटर करें इवन आफ्टर डिलीवरी। Certain complications, adoption, यानी कि डिलीवर हो गई, ये बस खत्म काम no. You have to monitor the mother for certain complications. Patient may have mortality. She may go into irreversible hypovolemic shock if she presents late to the hospital. She may go into acute renal shutdown. Acute renal shutdown होगा जब शॉक में जाएगी, वेसोस्पाज्म होगा, जो रीनल वेसल्स हैं वहाँ पे वेसोस्पाज्म हो जाएगा, रीनल परफ्यूजन कम हो जाएगी और पॉलिटिक हो जाएगी, क्योंकि शॉक में जो है सर्कुलेशन इज डाइवर्टेड टू वाइटल ऑर्गन्स लाइक ब्रेन, हार्ट एंड लंग्स. So this is the reason of renal failure. DIC I have already told you, मैंने आपको पहले बताया कि किस तरह से DIC हो सकती है. DIC में यह है कि आपको जो retroplacental clots हैं, जो hematoma है, it will throw thromboplastin into the circulation, it will use all the clotting factors and it will lead to DIC. APH के there are various reasons for PPH, Couvelaire uterus, दूसरा DIC, दूसरा uterine atony. So all they will lead to PPH. RH sensitization. If RH is a negative mother, then she must receive RH, anti-RH antibodies. Then complications of massive transfusion. As the patient is in shock, she is pouring blood and she needs massive transfusions. Abruption patients sometimes they need 8 or 10 transfusions because they have lost blood immensely. So these transfusions may have transfusion reactions. This is how this coagulopathy takes place during abruption. Abruption quick, clots it thromboplastin release way, activation of plasminogen, and it will convert plasminogen is converted into plasmin. It will convert fibrin into, it causes lysis of the fibrin. The fibrin lysis start happening. And here this thermoplastins, it will start extrinsic coagulation pathway. Fibrin is converted into fibrin, and this fibrin undergoes fibrin lysis and DIC. Now the fetal complications include fetal distress, hypoxic breathing injury, repeated episodes of bleeding, they will lead to growth restriction, and also. So these are the fetal complications. This is the comparison between placenta previa and placenta abruption. Placenta previa, as you already know, a lower line segment. If the placenta is situated in the low uterine segment, low lying placenta, it is called placenta previa. And while the placental abruption is usually often a premature suppression of the anomalous placenta. So clinical features, lateral bleeding is painless, appears to be or it is very painful in case of abruption. And in previa, bleeding is almost repeat. It will be bright red in color and it is proportionate to the visible blood loss. And it's not necessarily features of preeclampsia may not be present. While in abruption, painful bleeding attributed to preeclampsia or trauma and is continuous. There is revealed bleeding or concealed or mixed. Dark colored blood out of proportion to the internal shock, and it is preeclampsia or hypertension associated in these cases. On examination, the height of fundus and the consistency of the uterus in malpresentation with the heart sounds. Uh, there is in previa, the height of gestational age is usually according to the gestational age. The uterus is soft and relaxed. Malpresentation is common. The fetal head is high floating, and fetal heart sounds are known. In case of abruption, the uterus is usually enlarged and then sealed up. The uterus is tense and tender, rigid. There is malpresentation is unrelated. The head may be engaged, and fetal heart sounds are usually absent, especially in concealed life. When we do ultrasonography, placenta is the role in the uterine segment of the placenta previa, while it is in upper segment of the abruption. Vaginal examination, placenta is felt in the lower segment. In case of placenta previa, while placenta is not felt on the lower uterine segment, blood clots should not be confused with placenta. So this is how we compare placenta previa and placenta abruption. On the basis of clinical features, on the basis of abdominal examination, ultrasound, and examination. Now, what is the conclusion of today's talk? Abruption placenta is the leading cause of maternal and fetal morbidity, and it has both maternal and fetal morbidity and mortality. Etiology is poorly understood. There are certain risk factors which are associated with abruption, but various management options are available. Either we can manage conservatively, or there is aggressive management, or there is uh, we can induce labor and change. After the initial assessment of the patient, the subsequent management is aimed at resuscitation and prolongation of pregnancy if possible if babies return. Delivery is expedited only for maternal and fetal indications. So, about maternal indications of the patient is going to a irreversible shock, and fetal indication when baby has fetal distress, then we will expedite it. Thank you very much for listening. Uh, Now I want to ask if you have any questions, you can ask.